Hello, my name is Sarah Tamizuddin, and I'm an internal medicine resident at Scripps Green Hospital. Today I'm discussing primary myelofibrosis and the cutaneous manifestations that can herald transformation into a blast crisis. So primary myelofibrosis, or PMF, falls into the category of myeloproliferative neoplasms, which includes PMF, polycythemia vera, and essential thrombocytopenia. Unfortunately, PMF has the highest mortality rate of the three. Approximately 20% of patients with PMF progress to AML within 10 years. Getting to the case, a 75-year-old female presents with 2 months of a new rash associated with progressive dyspnea. Her medical history is significant for a 10-year history of myelofibrosis on Jakafi for the past 6 years. She also has a history of biopsy-proven Sweet syndrome 3 years prior. So Sweet syndrome, also known as acute febrile neutrophilic dermatitis, is a skin condition that's characterized by the abrupt onset of painful skin lesions, often associated with fevers and malaise. Her rash at that time had been painful and pruritic. In Figure 1, you can see the rash. She, however, didn't have any systemic symptoms or any signs of progression of her PMF at that time, and it self-resolved. Sweet syndrome is usually idiopathic in 50% of cases, but it can be associated with hematologic malignancies as well as in solid tumors, and even as a drug reaction. On this presentation, her exam was most pertinent for some tachycardia on her vital signs and then her skin rash that you can see in Figures 2 through 4. She has a malar rash on her cheeks, as well as erythematous, scaly patches and plaques on both the upper and lower extremities. She also had a petechial rash that was most notable on the lower extremities. Her labs were significant for an acute anemia with hemoglobin down to 5.3. Her baseline was 9. And on peripheral blood smear, she had 9% blasts. Multiple prior peripheral blood smears had shown 1% blasts or fewer, so this was concerning for progression of this patient's myelofibrosis. Progression of myelofibrosis can occur in 2 different ways. It can occur into the accelerated phase, which is characterized by 10 to 19% of blasts on either the peripheral blood smear or bone marrow biopsy. Or it can be progression into blast phase, which is the presence of greater than 20% blasts in either the peripheral blood or the bone marrow biopsy. And transformation into blast phase or transformation into acute myeloid leukemia is associated with a poor response to treatments and overall poor prognosis. So her skin biopsy revealed interface dermatitis with a small population of atypical mononuclear cells, which was consistent with leukemia cutis. Leukemia cutis is a manifestation of some hematologic disorders and has been seen in transformation into AML. So subsequent bone marrow biopsy showed that she had 22 to 25% blasts, consistent with transformation into AML, despite having only 9% blasts on her peripheral blood smear. So she was started on induction therapy and had initial improvement in her rash and reduction in her blast count, but unfortunately she had a relapse about a month later and went home with hospice care. So cutaneous involvement of myelofibrosis often represents extramedullary hematopoiesis, but it can have a broad differential. This patient had 2 distinct cutaneous manifestations of her hematologic disease. Initially, a neutrophilic dermatitis consistent with Sweet syndrome, and later leukemia cutis, which heralded her transformation to secondary AML. Physicians should note that dermatologic manifestations of AML may be present before peripheral blood smears indicate progression, and that leukemia cutis may warrant a bone marrow biopsy even if the peripheral blood smear doesn't show significant blasts. As in our patient, leukemia cutis may be the first manifestation of leukemic transformation in a myeloproliferative disorder. There is no standard treatment for leukemic transformation. Participation in clinical trials is highly encouraged. However, no randomized or well-controlled studies have compared therapeutic approaches. Options range from supportive or palliative management to intensive induction chemotherapy and subsequent stem cell transplant. Thank you for your attention.